Hi, in today's ICD-10-CM chapter specific guideline, we will see about the MRSA conditions, Zika virus infection, coronavirus infection. This is Surya Johnson, your medical coding guide. Hi, in my last video under the ICD-10-CM chapter specific coding guidelines, we saw the first chapter, certain infectious and parasitic diseases. Under that, we covered HIV infections, infectious agents as the cause of disease classified to other chapters, infections resistant to antibiotics, sepsis, severe sepsis, septic shock infections resistant to antibiotics. We covered these four parts in my last video. As a continuation of the chapter 1, certain infectious and parasitic diseases, we will see the remaining MRSA condition, that is the methicillin resistant Staphylococcus aureus conditions, Zika virus infections, and coronavirus infections. If you have not watched my previous ICD-10-CM guidelines, I'll put a link in the description box below and also somewhere here, so you can watch that first and then come to this guideline as a continuation. So before starting this one, we'll know what is methicillin resistant Staphylococcus aureus. So methicillin is an antibiotic. Resistant means this Staphylococcus aureus cannot be killed by this methicillin antibiotic. It can resist that one. So this condition is called methicillin resistant Staphylococcus aureus condition, MRSA conditions. In this, the first one, selection and sequencing of MRSA codes. So when there is already a combination code for MRSA infection available, we should always go and code that combination code. We should not code separately the MRSA infection and then resistant to penicillins. We should not code this B95.62, which is MRSA infection, as the cause of disease classified elsewhere, and Z16.11 resistant to penicillins. Because if there is already a combination code that describes the condition and also this MRSA, then you should code only that one. Because this B95.62 MRSA infection as the cause of disease classified elsewhere, it means this is a cause of something disease that is classified separately, that is elsewhere, somewhere else the disease has been separately classified. In that scenario only, you'll code that disease and then this MRSA. But when there is already a combination code, for example, in the slide you can see A41.02, which is sepsis due to methicillin resistant Staphylococcus aureus. This describes what is the problem, that is the sepsis, which is caused by MRSA. So there is a combination code. This you should not split and code as sepsis. There is a different code for sepsis alone. You should not code the sepsis code alone and then followed by B95.62. No, that's a big no. If there is already a combination code, you should go for that. You should neglect the separate individual codes in this scenario. So in case, if some people are asking me like these two codes also justify the case, like coding sepsis separately and this B95.62 separately also justifies. No, even if it justifies, when there is a combination code, it should be coded. We already saw this in the general coding guidelines. Another example here is if there is a pneumonia to the patient because of this MRSA, then we will be coding J15.212. This is another example to show you there is a combination code that exists. So in this scenario, we will be coding J15.212, pneumonia due to methicillin resistant Staphylococcus aureus, instead of splitting these things into pneumonia as a different condition. There is also a code for pneumonia separately and MRSA B95.63. So you should not split and code when there is a combination code. So that is the guideline here. And this combination code and splitting of two codes applies to all the guidelines in all the chapters. So whatever chapter you find these combination codes, you should always go for the combination code instead of splitting the codes and coding it as 2 or 3 different codes. So this is universal throughout the ICD chapters. So the 1B here is other codes for MRSA infection. So we saw about the combination code. What if there is no combination code exists? If the infection that does not have a combo code, in that case you will code the condition diagnosis and then you will code the B95.62, which is the MRSA infection as a cause of disease classified elsewhere. So this is how you code if there is no combination code exists. So in this 1C, MSSA and MRSA colonization. MSSA means Methicillin susceptible Staphylococcus aureus, and MRSA colonization. So what is first colonization? We should know. Colonization is also called as carriage. Like the patient will be positive. So if the patient has an MRSA screen or MRSA nasal swab, the result will be positive, but the patient will not have any illness. There will not be any diseases, or the patient will not suffer any symptom or signs or any conditions because of this positive MRSA or MSSA thing. In this scenario, the patient is called as colonized or a carrier. So what is colonized or carrier? The patient is positive necessarily without any illness, but the patient is not having any condition, any symptom or any illness. But there are high chances of this patient to transfer the infection to others, to transfer this colonization to others, so which might cause a disease to other patients. So in this case, if the patient is found to be MRSA screen positive but is a carrier without any illness, we will be coding Z22.322, which is carrier or suspected carrier of MRSA, or if the patient is an MSSA carrier, we will be coding Z22.321, which is carrier or suspected carrier of MSSA. So this is how we code when the patient is positive without any illness. So in the next scenario, 1D, MRSA colonization and infection. In this scenario, the patient is already a carrier and then later they got an infection. In this scenario, you will be coding Z22.322 along with the MRSA infection code. First, the patient was a carrier, then it converted into an infection, so you will code the carrier status and also the infection code. So under chapter 1, the next F is the Zika virus infections. So in this, the first one, code only confirmed cases. So if the patient is confirmed having a Zika virus infection, we will be coding A92.5, which is Zika virus disease. But if the patient is not confirmed, either the patient is suspected or possible or probable, if the doctor has documented or the lab is documenting suspected or possible or probable, in that case it is not confirmed. You can apply these words in the entire ICD-10 guidelines wherever you find a diagnosis or a condition documented, but before that or after that it's mentioned as suspected, possible, probable, then this means it's not confirmed, that the doctor has as a doubt that may or may not the patient has this condition. So wherever you find these words, you will be considering this as not confirmed. So for the Zika virus infection, if it is not confirmed, you will be coding Z20.821, which means contact with or suspected exposure to Zika virus. So the possibility of the patient having exposed to some Zika virus infected patient. So in that case, we will be coding this Z20.821. Next, we will move on to the popular guideline of the current years, chapter 1G, coronavirus infection. In this chapter, number 1, COVID-19 infection due to SARS coronavirus 2. This, the A1 is the code only confirmed cases. It applies to all the disease condition or infection. So if the patient has confirmed coronavirus infection, then you will be coding U07.1, which is COVID-19. Or if the doctor or the file or the lab result states the patient is suspected, possible, probable or inconclusive, in this scenario we should code these signs and symptoms only, and you should not code the confirmed diagnosis because it's not confirmed but the physician is suspecting. In this scenario, code only the signs and symptoms. So the next one under COVID-19 infection, 1B, sequencing of codes. So when the patient has a COVID infection and there are some other conditions, manifestation because of this COVID, then you will be coding U07.1, which is coronavirus disease 19, and then you will code all the associated manifestation, whatever conditions or symptoms the patient is having because of this COVID, you will code everything as an add-on code, manifestation code. So in this scenario, the exceptions are when there is a COVID-19 infection that later progresses to sepsis, severe sepsis and septic shock, you will follow the sepsis, severe sepsis and septic shock guidelines, in which will be the sepsis or severe sepsis, septic shock will be the first primary diagnosis, followed by COVID-19 and then the associated manifestation. The next scenario here is COVID-19 infection in pregnancy, childbirth and the puerperium. We have already seen about this in the general guidelines, right? So when there is an O code, the pregnancy, childbirth or puerperium code, always that will proceed. So you'll code an O code followed by COVID-19 code, and then the manifestation codes. This also applies to COVID-19 infection in newborn. So there's a separate code for that. And if the patient is a lung transplanted patient, then that will be an exception in this case. So the next one is 1C, acute respiratory manifestations of COVID-19. The same B rule applies here. You will code the U07.1 COVID-19 followed by the respiratory manifestations. So for the 1C, we will see some examples. For example, if the patient has pneumonia due to coronavirus disease, you will be coding U07.1, and then pneumonia due to coronavirus disease J12.82. If the patient has acute bronchitis because of coronavirus, you will be coding U07.1 followed by J20.8, which is acute bronchitis due to other specified organisms. The third one will be lower respiratory tract infection because of COVID-19. You will be coding U07.1, then J22, unspecified acute lower respiratory infection. Another example here, when there is an acute respiratory distress syndrome because of the COVID-19, we will be coding U07.1 followed by J80. The same thing applies to acute respiratory failure as well. You will be coding U07.1 followed by J96.0. So this is how you will be coding acute respiratory manifestation because of COVID-19. And the 1D states non-respiratory manifestations of COVID-19. The same rule applies. So U07.1 as the principal diagnosis followed by what and all manifestation. Even if it's non-respiratory, you'll be coding everything as secondary. So the next one in this is 1E, which is exposure to COVID-19, which means the patient has been exposed to a COVID and is symptomatic or a positive patient. So in this scenario, even if the patient is asymptomatic, that is without any symptoms, or symptomatic with symptom, if the patient's swab result states that patient condition is ruled out, that COVID-19 is ruled out, which means there is no COVID-19, it's negative, or it's inconclusive. The lab cannot find out whether it's positive or negative, it's in between inconclusive or unknown. If the status is unknown, in this scenario, you will be coding Z20.822, which means contact with and suspected exposure to COVID-19. So this will state that the patient has an exposure to a COVID-19 infection. The patient might be symptomatic or asymptomatic, but the result is either negative or inconclusive or unknown. In this scenario, you will be coding the Z20.822. So if the patient test result comes out to be positive or confirmed, in this scenario, you will be coding the 1A scenario, which is U07.1 COVID-19. If the patient is asymptomatic but is positive to COVID-19 test, you will be coding only U07.1. If the patient is symptomatic and positive result, you will be coding U07.1 followed by the symptoms. So the next one, 1F, screening for COVID-19. So if the patient comes to the facility only for screening, in this scenario, you should not code that encounter for screening for COVID-19, because the description, very much excites you to code that one, Z11.52, which is encounter for screening for COVID-19, but you should not choose that code. Instead, you should always choose Z20.822. So whenever a patient is coming for screening, so the patient should be considered as a contact with or suspected exposure to another COVID-19 patient, like that. So you should always consider a patient who is coming for screening as an already exposed or contact with COVID-19 case. So Z20.822. So the next one here is 1G, signs and symptoms without definitive diagnosis of COVID-19. So the patient has some signs and symptoms, but the COVID-19 is not confirmed. In this scenario, you will code the symptoms, whatever symptoms like acute cough or shortness of breath, fever, whatever it is, you will be coding those symptoms. So in this case, if the patient is not like suspected exposure to COVID-19, you will code only the symptoms. But if the patient has symptoms and also the patient has some suspected contact with or exposure to COVID-19, in this scenario, you will code the symptoms and also Z20.822 as an additional diagnosis. So the addition of Z20.822 will be only applicable if the patient has suspected contact with a COVID-19 infected patient. So the next one, 1H, asymptomatic individuals who test positive for COVID-19. If the patient is asymptomatic, which is the patient does not have any signs or symptoms, but when tested, the patient turns out to be COVID-19 positive. So in this scenario, you will follow the 1A, which is code only confirmed cases. The patient is confirmed positive. So you will be coding U07.1 COVID-19. So if the patient with a history of COVID-19, the patient doesn't have any symptoms, or now the patient is not positive but has a history of COVID-19. In this scenario, you will be coding Z86.16, which is personal history of COVID-19. So the next one, 1J, follow-up visits after COVID-19 infection has resolved. So the patient now does not have any COVID-19 infection. It's been resolved completely, but the patient is coming for a follow-up visit. In this scenario, you will be coding C09, which is encounter for follow-up examination after completed treatment for conditions other than malignant neoplasm. So there is nothing specifically to COVID-19 mentioned here. So in this scenario, you will be coding other than malignant neoplasm. And additionally, you will be coding Z86.16, which is the personal history of COVID-19. So some people might have a doubt here. If the patient is coming for a follow-up visit after COVID-19 infection, but the patient is still having some symptoms or conditions related to that previous COVID-19, we'll see in detail about that in the same chapter under the M option. So the next one here is the 1K, encounter for antibody testing. So if the patient encounter is for the antibody testing, which is not being performed to confirm the current COVID-19 infection, which is the patient is not visiting to confirm again testing for the COVID-19 infection, and it is not a follow-up test after the resolution of COVID-19. So in this scenario, it is only for the encounter for antibody testing. So you'll be coding Z01.84, which is encounter for antibody response examination. So you should have in mind, so when the patient is coming for antibody testing, it should not be a condition where the patient is coming to confirm the current infection or as a follow-up testing of the previous COVID-19 infection. Only this encounter should be purely for antibody testing. Then only you should code this Z01.84. So the next one here is L, multisystem inflammatory syndrome. So in this scenario, when the patient has a multisystem inflammatory syndrome, so that syndrome is a group of signs and symptoms, it involves the multisystem, various systems. So in this scenario, when the patient is confirmed COVID-19 and which results in multisystem inflammatory syndrome, you will follow the usual guideline we saw. You will code U07.1 COVID-19, then followed by the manifestation. So in this scenario, the manifestation is a multisystem inflammatory syndrome. So you will be coding M35.81. Under the same multisystem inflammatory syndrome, the patient is not positive right now but has a previous history of COVID-19 with a multisystem inflammatory syndrome. So in this scenario, you will be coding M35.81 as the principal diagnosis, followed by U09.9, which is post-COVID-19 condition unspecified. So this one you should remember about the general coding guideline we saw. What is the reason for visit? So if the reason for visit, the patient is COVID positive with the syndrome, you will code the positive first and then the syndrome second. So if the patient has a history of COVID and he's coming for the multisystem inflammatory syndrome to be checked out, you will be coding M35.81 as principal, followed by the post-COVID-19 infection condition. Also, you should note that you should not code U09.9 when there is an active COVID-19 infection. It is because it states post-COVID-19 infection. So when there is an active COVID-19 infection, we will code it as confirmed COVID-19 infection followed by the MIS. So the next one here is under the multisystem inflammatory syndrome. If the patient has known or suspected exposure to COVID-19. So the patient has an exposure to COVID-19 and also the patient has a multisystem inflammatory syndrome. So in this scenario, you will be coding the multisystem inflammatory syndrome as principal, M35.81, followed by the contact with or suspected exposure to COVID-19. You will not code the Z20.82 as principal because it's not yet confirmed. So you'll be coding MIS as the principal one, followed by the contact or suspected exposure to COVID-19 infection. So the next one, under the coronavirus COVID-19 infection, M, post-COVID-19 conditions. So what is post-COVID-19 conditions? It means like the patient previously infected with COVID-19 or tested as positive COVID-19 has developed a condition, but the COVID-19 the result has been changed to negative after several tests. The COVID-19 is changed to negative, but that condition still exists. So if the patient is coming to be treated for those post-COVID-19 conditions, you will be considering it as a sequelae of COVID-19. So in this scenario, you will be coding the specific symptoms or conditions related to that previous COVID-19 infection, then followed by the post-COVID-19 condition unspecified U09.9. But this U09.9 you should not assign for manifestation of an active current COVID-19 infection. So if the patient is having a current infection and there is a manifestation, in this scenario you should not code U09.9. This U09.9 should be applied only for the conditions that are like sequelae of the previous COVID-19 result, not because of the current COVID-19. You might have a question like the patient has a previous positive, the patient is previously positive that has resulted in a condition like a disease has been developed because of that, and that condition is still existing. The patient result has been turned to negative, but still the condition is existing. Like I'll put it in this way so you can understand. Like for example, the patient is first been tested positive in May, we'll say like that, in May, and after that the patient has developed a condition or disease because of that COVID-19 infection. Later at the end of the May, the patient result for COVID-19 is negative. The patient became negative again, but that condition still existing. So after like 2-3 months, the patient is having that condition still, but the patient is COVID-19 negative. Later, like we'll say, now the patient has that condition, and in November the patient is again tested positive for COVID-19. So when the patient is coming to the visit with the previous COVID-19 related condition and current COVID-19 positive result, in this scenario you can code U09.9 also along with U07.1, which states that current COVID-19 positive. And if there is any new manifestation or active infections related symptoms, you will be assigning that also. Hope I didn't confuse you. The next one is 1N, under immunization for COVID-19 status. So if the patient has not received even one dose of immunization, you will be coding Z28.310 unvaccinated for COVID-19. So the patient has not received even a single dose. So it is considered as, the patient is considered as unvaccinated for COVID-19. So if the patient has received any one or few of the doses and has not met that fully vaccinated status as per mentioned by the CDC, in this scenario you will be considering the patient as partially vaccinated, like the patient has already initiated the vaccine but has not completed, or the status of the patient is not becoming fully vaccinated as per the CDC, you will be considering as partially vaccinated for COVID-19. So you will be assigning Z28.311. So that's all about the chapter specific guidelines. Chapter 1, certain infectious and parasitic diseases. So we covered all the certain infections and parasitic diseases in my videos. The previous video we saw about the HIV to sepsis, severe sepsis and septic shock infections resistant to antibiotics, and in this video we covered the MRSA conditions, Zika virus infections and coronavirus infections. Hope this chapter 1 is clear to you. If you have any doubt in this chapter 1, certain infectious and parasitic diseases, you can very well ask it in the comment section below, and I am more than happy to answer all your queries. So in my next video under the ICD-10-CM series, we will be seeing the next chapter 2, which is the neoplasm, C00 to D49 series. Hope this video was useful to you. If you found this video to be useful, please hit the like button. That will really mean a lot to me. And if you're new to this channel, please subscribe and hit the notification icon so you'll not miss any of my future ICD-10-CM or any videos related to coding. This is Surya Johnson, your medical coding guide.